I'd like to extend a really warm welcome to you on behalf of Brain Injury SA and also our presenting partner, the Lifetime Support Authority, to Assuming Control for 2016. We're thrilled to have put together what we think is a really interesting lineup of guest presenters, including, of course, today's presenter, Dr. Richard Clark, who will be talking through neurotherapy for the injured brain. Before he does that, I've just got a few minor housekeeping matters to attend to. First of all, in the case of an emergency, an alarm will sound. We have exits at the rear of this room, and then to exit the building, there's the main entrance and also fire doors to the left and right. Toilets, we have the women's and disabled toilets outside and to the left, and the males around to the right. We are also filming this event as well, so for those madly writing down notes, rest easy. We are filming the events, and that will have all the slides there as well. If people could keep their mobile phones on silent for the duration of the session, that would be appreciated. Richard will be taking questions, a few questions throughout his presentation, so if you have something burning that you need to ask for clarity, please ask away. There will also be time for questions at the end of the session. And yeah, I think that's basically it. Also, everyone's welcome to stay for morning tea at the conclusion of the session. So I'd now like to welcome Brain Injury SA's CEO, Natana Davey, to formally introduce Dr. Richard Clark.
Thank you, Ed. That was lovely. Well, good morning, ladies and gentlemen. Firstly, I'd like to say what a beautiful day it is today, and I'm very happy to be here sharing it with all of you, and especially because it is a little bit warmer than it was yesterday. I would like to firstly acknowledge this land that we meet on today as the traditional lands for the Kaurna people, and we pay respect to their spiritual relationship and their country. Before I go on to introduce our special guest speaker, I'd like to say a special thank you to those that have made today's Assuming Control event possible, which of course includes our wonderful and dedicated team at Brain Injury SA, the team at Yellowwick and also the team at Studio C. But importantly, I'd like to take this opportunity to say a big thank you to our presenting partner, the Lifetime Support Authority. Without their support, their dedication and generosity towards us, this event would not have evolved to be what it is today. So I'd particularly like to thank the CEO, Lois Boswell, and her amazing team at Lifetime Support Authority. Again, following on from what Ed has already let us know, we are excited to be showcasing a lineup of experts and equally excited to be kicking off this first event of Assuming Control with you all today. So thank you for joining us. It is my pleasure to introduce Dr. Richard Clark. And for those that do not know, Dr. Clark is Emeritus Professor of Psychology at Flinders University and the past head of school. With a long list of publications behind Dr. Clark, it is exciting to be able to hear from one of South Australia's leading experts on the brain and acquired brain injury. Through Dr. Clark's dedication and passion, he has published over 200 articles in peer-reviewed journals and books, and his significant contributions have been recognised by his appointment as a Fellow of the Australian Academy of Social Sciences. In addition, Dr. Clark's extensive research and teaching, he has been a practising psychologist since 1987 and is currently the co-clinical director of brain health clinics here on South Terrace here in Adelaide. Dr. Clark helps people with brain injuries and other conditions through neurotherapy, which is the topic of today's presentation. So please join me in welcoming Dr. Richard Clark. Thank you.
Thanks, Natasha. Welcome, everyone. It's good to be here. As Ed said, I'm happy to take some questions through, if for continuity or clarity, so that I don't leave people behind. It is a complex subject, so I'm trying to do my best to get the message across. But if I'm failing, you'd let me know and ask me the question. Okay. So, what is neurotherapy? Oh, before I start, is it clear at the back, my voice? Okay, thank you. So what is neurotherapy? It's really a brain-based approach to treating psychological and brain dysregulation or dysfunction. So it's working directly with brain function itself, what the brain is doing. So the first part of the talk today is going to be talking about that, and essentially what neurotherapy addresses and where it fits into the treatment mix for psychological and brain dysregulation or dysfunction. The rest of the talk I'll be talking about how, for neurotherapy, we assess brain function, and we use a technique, amongst others, called quantitative EEG, and I'll explain what that is and why it's useful and how we go about it. Then thirdly, I'll talk about the main forms of neurotherapy. There are others, but I'll go through the main ones. And finally, I'll talk about an assessment and treatment case example using neurotherapy in conjunction with other interventions. And as I go through the talk, I'll be covering other sorts of examples too. All right, so the first distinction I want to make to put neurotherapy in context is where it fits into the treatment mix. So obviously everyone knows about medication, and as a way of dealing with brain injury or various forms, or brain functional problems of various forms. And medication, usually for psychological purposes, works on up or down regulation of neuromodulators. And you've probably heard of some of the main ones: dopamine, serotonin, noradrenaline, and so on. And by a neuromodulator, we're talking about a neurotransmitter, an important chemical, information processing chemical in the brain. There's not so much concern with the working out what information is that's being processed from our senses in our body, but it's more concerned with sort of tuning up or down how active the areas of the brain are. So it's a very, very important distinction. And most of the medications that we use for brain and psychological disorders work on the neuromodulators. Others, there are some of them work on others, but the GABA, for example, on benzodiazepines is commonly used. The issue about medication, however, is it's although it's selective usually for particular neurotransmitters, it's not really selective for any particular part of the brain. And that's one of the downsides of medication. Cool. Okay, is that any better? Is that better? More? Okay. It's just someone up at the back's not hearing. How's that? Okay. Soft voice, okay. I'll speak up. How's that? All right. So what I'm saying is that neurotransmitters often are not, they're not really selective for any particular part of the brain. So if you've got a problem in one part of the brain or another, they're not going to just go for that. They'll go for the whole brain, and that's one of the difficulties in that by not being selective, they can actually cause changes in areas where we don't want to make changes in the brain. Then the second major category are psychologically based therapies, and these are ones that really are the sort of the talking type therapies usually. There are other types, mainly talking therapies, and what they're concerned with is trying to change the way you think or believe or act or behave to try and deal with the problems that you have. And you'd be familiar with some of the main types: cognitive behavior therapy, mindfulness, behavioral therapy. There's three of the examples there. So neurotherapy is the third intervention type I'm talking about here, and that's the one we're concerned with mainly today. And that's concerned with normalising, this is a really important distinction, normalising underlying brain function, pre-conscious brain function. So in neurotherapy, we're not talking about your memories or how you think or what you believe or how you behave. We're talking about the underlying systems of the brain, their regulation, and how well they're working to process information to allow you at the conscious level to make good decisions and act and behave. So pre-conscious brain function is what neurotherapy is working on. And there is a whole range of techniques that are available today, some with very good evidence, some with not so good evidence. transcranial direct current stimulation, repetitive transcranial magnetic stimulation, electromagnetic field stimulation, neurofeedback, hemoencephalography, low-level laser therapy. I'm sure many of you would have heard of quite a few of those. So what I want to talk about now is this pre-conscious processing that I'm talking about. It may not be immediately apparent to people, but every time we sample information from the environment or sample information from our body, it actually takes time to process that information to work out what it is we are apprehending. Okay. It actually takes, on average, about 4/10 of a second. Think about that. That's a long time. In fact, what the brain seems to be doing is it's sampling the environment every 10th of a second, or roughly about 10 times a second. So it's a digital sampling system, really. But for every one of those samples, it requires 400 milliseconds to go through and process what it is that's being apprehended to the point where it can be made available to conscious awareness. So you can see there's a whole different area here where things can go wrong. If that pre-conscious brain processing doesn't work for some reason, or there's got some problems with function, that's going to change and significantly impact on what we actually end up apprehending in our conscious brain. So that 400 milliseconds, if things go wrong, what we actually becoming consciously aware of is going to be misinformed to the extent that those pre-conscious processes are not working properly. Brain processes are not working properly. That's why, for example, a lot of talking therapies can't fix the problem, because they're talking about your conscious awareness, but with neurotherapy what we're talking about is determining how we work out what gets into conscious awareness, which is quite a different thing. So it's a very subtle but very important distinction. So there are four main steps. I mean, there are many ways of parsing this and breaking this up. There are four main steps I'm talking about here. I want to talk about, one is the sensory motor stage of this 400 milliseconds. That's where the brain, as I said, repeatedly samples information from the sensory world and from the body world, internal world, in order to prepare responses for them. And that involves one major system called the thalamocortical system. And I'll talk a little bit more about these systems in a moment. Then the next step in what the brain has to do, once it's sensed information and while it's working at what it is, almost at a cognitive level, information processing level, the emotional system has then going to get involved and has to work out what the salience of that information we're currently processing is. How relevant is it to us? Okay, so in that system, which is the limbic cortical system, works to process the body's emotional response to the stimuli we've just apprehended, okay, and to work out how important that event is emotionally and to help us determine what we're going to do. And that takes place at the next stage of attention and activation, because that emotional system plays a very important role in selecting out of all the information that we're currently processing in that sample, which part of that information set is important for us to shift our attention to and process and really pass on to conscious awareness so that we can deal with it in an appropriate way to satisfy our needs and goals. And that involves a number of other systems, in particular the brainstem, the vascular glial system for metabolic support, the cingulate system, which is a very, very important system in the middle of the brain, and the cortical system. And finally, once we've had our brain activated to focus on those elements of the sensory world that we're currently processing, that 400 milliseconds, a next stage occurs where those distributed activations that are involved with what, where, when, why, and so forth that we're currently processing is actually connected and bound together in a way, biochemically. It's bound together functionally, and it is that bound system, which usually involves a very, very large part of the brain, which is then presented to conscious awareness. That bit we haven't quite worked out how that happens, but that is the key precursor for us being consciously aware of what it is we started to apprehend 400 milliseconds ago. And so we're doing this every 100 milliseconds, and we really in a way, we're updating our working memory, our patterns of activation of what it is we're apprehending from moment to moment. And that becomes the basis of our conscious awareness. So with neurotherapy, what we are dealing with are all these systems. Okay, so here's a diagram which tells us something very important. I've diagrammatically represented all those 4 or 5 systems I've talked about in the previous slide. Don't get overwhelmed with a lot of information. But the key thing I want to point out here is that each of these systems, the thalamocortical system, which is processing sensory information, the limbic cortical system, which is processing emotion and valence to understand the meaning of the sensory information we're processing, the brainstem modulatory system, which activates the brain in the relevant areas so that we can shift our attention to the relevant information we're just sampling, the vascular glial system, which is important for making sure the blood flow goes to the areas that are doing that processing, and finally the cortex itself, which is actually holding those representations and which get bound together to give us the information we need for working memory and for mental and conscious processing. The thing is that each of those systems gives us characteristic signals in the EEG. That's the electroencephalogram. And the electroencephalogram is essentially, if you put electrodes on the head, it's the electrical fields that we can pick up from the scalp. Okay, right across the scalp, we can pick up those electrical fields across a range of different rhythmic frequencies. And the thing is that each of these different systems that I just pointed out to you is characterized by different frequencies, by different sorts of rhythms. So, for example, the thalamocortical system, the first one, which is this one here, can be seen to be reflected in the alpha rhythm, which probably many of you have heard of those. That's probably one of the best known rhythms of all. The sensory motor rhythm, beta rhythms, all you can see the different frequencies. The word Hz stands for Hertz, which means number of oscillations per second. The limbic system here can be seen in characteristic frequencies in the theta range, 3 to 7 oscillations per second. The brainstem can be picked up through oscillations which are very, very slow. As you can see, 0.1 to 2 cycles per second. The vascular glial system, which provides the energy, also has a very, very slow rhythm which can be detected, ultra slow rhythm. And finally, the cortex itself, within cortex itself, we see very, very fast rhythms from about 25 up to, well, some people think even up to 1,000 cycles per second. So this is the important thing. So I've described the systems that are involved in us processing and understanding the meaning of information that we can attend to and to decide how to use that information to satisfy our needs on a moment-to-moment basis. I've now talked about the fact that we can actually obtain objective markers of the operations of those systems. And the key thing when we get further into neurotherapy is to actually, in someone who's got an injured brain, to look at those markers, markers of the brain rhythms, and to assess the extent to which those rhythms vary from normal. And so it's a parametric assessment relative to, say, a normative database for men, women, children of the age of the person that we're assessing. So in the end, when all that processing takes place, we find that it's the convergent activity of all these systems, thalamocortical, limbic cortical, corticocortical, vascular glial and so forth, limbic, they all work together at each of the different points in the cerebral cortex, and a competitive process takes place through the interaction and synergistic activation of these systems to activate particular areas that are relevant to the events that our emotional system tell us that we need to process now that's important for us and satisfaction of our needs or the risks that we might be in that moment. And that happens right across the brain, so that in the end we get a network of regional activations that are relevant and represent the things that we need to attend on a moment-to-moment basis and which enter our conscious awareness for us to deal with at a mental level. So that's really the model, put very simply, that we work with, or at least I work with in neurotherapy, to try and understand and access information in the brain of the individuals who've got some injury or other, for the purposes of assessment and treatment. Here is an interesting image. This is something I did in the late 90s, as part of a research project at Flinders, where we put people in, put an electrode cap on people. In those days I had 128 electrodes. It was a really busy cap spread across the scalp. And in this particular example, what we were doing was we wanted to see what the electrical fields looked like as someone received some sensory information and then processing that information to the point where they became consciously aware of that event. So we got them to focus on a computer screen, they looked at something, in this case it was just a single word, and they had to assess with the relevance of that word. That was the experimental task. And while we were doing that, we measured the brain electrical activity from the scalp while they were doing that. What I want to point out to you is, what I want to do is have a look at the brain electrical fields that occur over the scalp. This is over about 400 or 500 milliseconds, and it's sped up 40 times. And you can see here when at 800, we're starting to process information. You can see the electrical fields are moving across the scalp very rapidly as the information is processed, and gradually they resolve into a clear pattern on the scalp. And that's the working memory pattern I talked about before, which is the network that is created as the brain has worked out what is relevant to us to attend to and deal with at a conscious level. The fact that the red and blue just deals with negative versus positive voltages, one or the other, that's all. So all the things I'm talking about have been shown experimentally to be the case. We do produce electrical fields, they do change rapidly as we receive new information, and they do, within 400 milliseconds, stabilize into a fixed pattern on the scalp to represent, where that pattern is representing the network activation, representing the event being attended. All right, so summary so far. What I've tried to point out is that dysregulation in pre-conscious processing, this 400 milliseconds or so, impacts conscious awareness and actually can even impact conscious understanding. It can change our interpretation of events. It can affect where we're going to be shifting our attention. It can affect the extent to which we can hold information in mind for any significant period of time. In many disorders, traumatic brain injury, schizophrenia, Alzheimer's, depression, anxiety, attention deficit disorder, there's a whole range of them. All of those disorders have one thing in common: a failure at the highest level of brain functioning for the individual to hold online a working memory pattern which subserves conscious awareness. And you find a lot of those disorders, that working memory pattern just keeps dropping out, and the attention falls away, and they have to keep re-establishing it. Very, very difficult, very, very hard for people. And those of you who've seen people with traumatic brain injury would have seen how difficult they often find it to attend to things, to hold their mind on things, to remember what they're doing. Everyone's seen it. And you've also probably seen how it affects their affect, how they start to get depressed and anxious and worried about things, and so on.
Richard, does that also relate to fatigue as well? And fatigue is a really common...
Yes, absolutely. Yeah, if you've got fatigue for whatever reason, whether it's due to blood flow, with, oxygen and glucose, or whether it's due to other metabolic deficiencies or some viral problem, what it really means is you haven't got the resources to do what you need to do, and so you haven't got the capacity to retain information online. Look, as I said there in the second one, many disorders linked to global neuromodulatory or metabolic anomalies. In fact, one of the interesting things is in a lot of these sorts of disorders, the brainstem gets impacted, particularly in problems like in TBI, because it's in a very bad place, as we'll see a bit later on. And that brainstem is the area that has all the cell bodies for all the neuromodulatory systems of dopamine, noradrenaline, serotonin, acetylcholine, histamine, and so forth. And if that gets impacted, your capacity to up and down regulate the amount of energy that's an activity in the brain to deal with the demands of the moment gets impacted negatively and seriously. And that neurotherapy seeks to normalise preconscious functioning. And as we'll see as we go through, it tries to do this by trying to deal with these electrical fields I've talked about and to try and retrain them or get them to work in a more normal way, to regulate them better. And the important thing is to understand is that neurotherapy, in some cases, can work on its own, but often it works well in conjunction with other therapies, such as psychological therapies and behavioural therapies, and also pharmacotherapy, drug therapies. Often we find that sometimes psychological therapies alone in someone who's got an injury may not work overly efficiently because people with a brain injury are finding it just too hard to carry out the disciplines required to make the mental and behavioural changes to get back to normal. So with neurotherapy, that often allows people to get some pre-treatment to the point where they're actually more able to deal with those sorts of demands. So working together conjunctively is a very important thing in many sorts of brain injury. Okay, so I'll just stop there. Anyone completely lost? No? Right, good. All right, so let's move on to the next stage. So we now talked about, what we're looking at in the brain, what we're looking for, and I've talked about quantitative EEG being a way of actually trying to assess if there are problems in these preconscious systems and the function of these preconscious systems. So now what I want to talk about is what is EEG and what is quantitative EEG. Again, don't be overwhelmed by the figures. The interesting thing about EEG, or the electroencephalogram as it's called, is that it works because of a really unusual quirk of nature. And that is that in the brain, in the cerebral cortex, which is the outer part of the brain, just underneath the scalp, there are a sort of cell called pyramidal cells. They're shaped like pyramids, as you can see. There's the examples of them there, these things down here. These are nerve cells, pyramidal nerve cells, and what makes them really distinctive is they're all lined up like little ducks. So they're all lined up parallel to each other. And they're all lined up parallel to the surface of the cerebral cortex. And what that means is that when those cells are playing their role in processing information, in the way we talked about before, that each of them generates an electrical field around them because they're so shaped with such long axons. This is the output end, those long axons. They're so long that when they're carrying out the work of processing information, they create little dipolar fields around them with negative and positive poles. Everyone remember the iron filing story at school? Where you had a little magnet and you threw the iron filings on it and they formed a little field around it? Okay, well, that's essentially analogous to what happens to these brain cells. And because they're all lined up together, their fields that each of these individual neurons produce sum together and make it large enough for us to see on the scalp. So that's the magic that we're lucky for with respect to EEG. And so by placing electrodes on the scalp, we've got an example here, we can actually see perturbations in those electrical fields on the scalp. And so EEG is really, as I call it, it's an epiphenomenon. It's really something that reflects the electrical fields of these neurons in the cerebral cortex and their activity as a result of the connections to them from subcortical areas. I've put down some statistics there. There are 50 million pyramidal cells that will be sampled underlying each electrode, which would be that big, you place on the scalp. 50 million. Think about that. So when we're doing EEG, we're not sampling individual neurons, we're actually sampling mass activity. But it's okay and it's enough and it's representative of what's going on. So here's what we would do. We'd put an electrode cap on someone's head, and we would attach the cable from the cap to an amplifier, which we would then connect to a computer and sample the electrical activity from the scalp on a millisecond to millisecond basis, so with very, very high resolution. So that's what we'd be capturing. When we're doing that, we will be capturing these oscillations that I talked about. Here's an example of what the EEG looks like. So with a cap on someone's head, we would see a running stream of squiggly lines like that, where each squiggly line represents the electrical field variations from an individual electrode over time. And that window would show, from one side to the other, about 10 seconds of EEG. And if you look at it, you can see there are very clear ups and downs, oscillations in the EEG over time, and they vary over time, and they vary from channel to channel, from line to line. So when we're looking at EEG, that's really what we're interested in. Because embedded in all of that, remember I spoke about before, all the different frequencies that are reflecting these different systems that are key to the processing of information. The theta rhythms, the alpha rhythms, the beta rhythms, the sensory motor rhythms, the gamma rhythms. All of them are critical, and what we want to know, as we'll see as we go through, is to what extent are these rhythms being produced normally within that person's brain. And you can see, if you look, this is just a slide I drew up to show an example. On the left here, here's an example of what normal EEG would look like in a healthy person, whatever that means. And then you can see the ones, one in the middle and the one on the right, are examples of EEG from people whose pre-conscious processing systems have been disturbed. And you can see the one in the middle, we can see a lot of relatively fast and high amplitude activity, which is normally indicative of things like someone's brain being chronically over-aroused. You probably see hypervigilance in the person, working memory systems, that's the capacity to hold things online stably over time would be impacted. And there'd be failure in a lot of the regulatory systems concerned with attention and with affect, your feelings. Similar problem on the one on the right. You can see here, in contrast, we see this excessive slow activity. Just compare that with the one on the left. And often, in this particular case, we can see that it's strongly over the back of the head, and that would tell us that there are problems with the way information in the sensory realm is being integrated together in the brain. There would also be working memory issues, and similarly there'd be regulatory systems failure. So I could see, just by looking at that that person's brain has got problems, that person's brain has got problems, and that one would be normal. But we go further than that because it's not just a matter of looking at the squiggly lines and saying, oh, well, I think this and I think that. That's a bit qualitative. We want more hard objective evidence or information about what's going wrong in the person's brain. So we get involved in mathematical and I'm not going to go into any details of this. We go through mathematical transformations. There are mathematical techniques that I don't understand. I'm not a mathematician, which allow us to look at an EEG trace like this over 2, 3, 4 minutes and to pull out how much activity there is in the frequencies, those little EEG oscillation rates that I talked about before. How much alpha is there, how much beta, how much sensory motor rhythm, and so forth. And how does that compare with a healthy control population? And then we can get statistics which tell us whether or not this person's brain, with respect to any of those systems, is working within normal range or not. Okay? And then what we would do is we'd look at that to assess whether or not the sort of symptoms that the person is presenting with converge with and are consistent with the sorts of regulatory systems failure we're seeing statistically in the EEG. So this is what we would do with a data set like that. We get all these squiggly lines which are very, very hard to interpret. They're hard for most of us to interpret. But with the mathematical transformations, we can convert a time-based analysis of the brain electrical fields into what's called a spectral plot. And what that tells us, if we look at this, This tells us over the different frequencies of interest, alpha, beta, gamma, theta, delta, and all that sort of stuff, and how much power there is at each of those frequencies. So that's the frequencies across there, that's how much power there is. And you can see, in this case, in this example, there's a huge peak in power at about 10 cycles a second for that person. So that's quite normal, in fact. That's for most people, that would be the alpha rhythm, which we would often expect to see. In the bottom area here, we do the statistics. And what we're looking at here are the frequencies, again, in this case from 0 to 30 cycles per second. But now what we're showing is variation from normal in terms of standard deviations. And the standard deviation, for those who are not familiar with it, is a measure of variation from normal. And if you've got a variation of, say, 2 standard deviations from normal, that means you are outside the values that we obtain from about 96% of the population. That gives you sort of a feel what it means. And so if we look at this case here, can't read those numbers actually. Let me just pop over and look. Yeah. That one there, just note that. So that is 2 standard deviations away from normal, and you can see this person's got activity in these frequencies. I think it's in the 5 to 10 hertz range that is excessive, well outside normal function. So by looking at that person's brain statistically like that, we can say immediately there are systems in that brain which are working outside normal range and are going to produce problems in the way that brain is processing information. That's pretty important information. By the way, this sort of analysis is quite reliable. The figures on the left here, which you can't see, tell us the reliability with which we're making those statistical inferences. And the way we deal with this EEG when we do these analyses is we do the analyses twice on separate sets of data, identify what's statistically abnormal in each of those sets, and do a correlation to see to what extent they agree. And if we get a high correlation on 2 independent sets of data, that means that the result is usually pretty reliable. The chance of it being incorrect is very, very low. And normally with these sorts of analyses, we get reliability measures of about 0.95, 96, up to 1, which means it's pretty reliable. And we measure not only, we measure both retest reliability and split half reliability, which are different sorts of reliability. So it's very important when we do these analyses to make sure that what we're saying is reliable. We're not just coming up with some numbers and crossing our fingers and hoping. So this next slide presents in more detail the same information that I've shown you. Here you can see abnormal activity in that range there. 2 standard deviations. Okay. So that's what we do in the assessment phase in terms of looking at the EEG. So any questions so far? Yeah.
Is this EEG having practical implications for things like diagnosing autism spectrum disorder?
That's a great question. I'm glad you asked that one. The thing is that the question was, can the EEG be used to diagnose things like autism spectrum disorder? The answer is no, it can't, because and there are a number of reasons why one can say that, and that's because the disorders, such as the one you've talked about, are disorders based upon clinical and behavioural assessment, usually from the Diagnostic and Statistical Manual, DSM-4 as it now is. So these are clinical categories that are invented based upon very old behavioural and clinical criteria, and are really not adequate enough. They're not at the same level of what's the word I'd use, discrimination as we would have with EEG. You can take any of those disorders and they can consist of wide ranges of heterogeneous clusters of symptoms, and they're all given the same label. Whereas the EEG, and we can actually see quite different profiles, all of which are consistent with a global label like ASD. Okay, so we're actually now at another level of detail. So, okay, yeah.
So basically, the data that you collect, so it's you don't use subjective data at all to analysis.
Oh yes, we do, because we can look at the brain, and then but we want to know in what way is that person not functioning well. So we want a clinical assessment, we want a neuropsychological assessment, and what we'd then be looking at is to see to what extent that presentation, symptomatically and neuropsychologically, converges with the information we get from the EEG. So if we see abnormalities in the area, say over the back of the head, so over the sensory integration areas, and the person presents with a learning disorder, then we'd say, well, that makes sense. So we're looking for consistency and convergence in the clinical setting. Yeah.
During the assessment, are you having them do anything, or is it just resting brain activity?
You can, often we only do resting. You can also do EEG whilst they're doing particular tasks if you're looking for particular things or you have particular hypotheses to test. But most of the time we were just looking at EEG at rest, because what we're really interested in is the extent to which the normal brain, the resting brain, when it's not under challenge, has systems that are operating within normal range. And they're passing information through them, of course, is another level of operation in the brain. Yeah.
What impact does pain have on if somebody's in pain? Does that recognise pain?
Well, pain is just one of a number of forms of sensation. EEG doesn't recognise pain. EEG recognises the functions of system. It doesn't recognise feelings. Okay, so that to understand whether a person is in pain, we'd need to do a different sort of analysis. We'd essentially do a symptom questionnaire or do some sort of neuropsychological test, or whatever. All right, so this is a simple example, a clinical assessment using quantitative EEG. This was the case of a 53-year-old male adult who suffered a blow to the right frontal region. It's over here, 4 years earlier. An initial magnetic resonance imaging scan, MRI scan, which of course looks at structure, not function, found no abnormality. But later on, another MRI of a different type did identify some small changes in the right frontal region, essentially with affected blood flow. The right frontal and also the left forceps major was subsequently seen. So we did a neuropsychological screen on this person, and you probably can't read the details, but essentially what we're looking at are self-regulation, feelings, that's depression, anxiety and stress, cognitive function in terms of processing speed, impulsivity, attention, concentration, information processing efficiency, memory in the verbal and visual spatial domains, executive functioning and so forth. So a wide range of information about that person, and this is a tool that we use a lot. And we get measures in either Z-scores or STEN scores on each of these indices, where a STEN score of 1 is in the red, which means you've got clinical level problems in that area. A score of 2 to 3 in the orange is when you've got borderline clinical. Grey represents a normal range, so you're operating with normal range. And the green colours represent superior range. And the dots represent where this person falls. And you can see in this case, this person had significant problems across a whole range of cognitive and affective measures. We don't need to go into detail, but clearly they're quite serious. This is what that person's EEG looked like. Now, if you remember looking at the EEG earlier, I think that looks pretty clear even to you after 10 minutes that looks pretty abnormal. And then we did the statistics, as you can see on the right, and that red line at the bottom here is showing these 2 standard deviation criterion. That's the standard deviation axis across the range of frequencies. And you can see huge amount of abnormal activity across a range of different frequencies, across those different systems that I talked about before. So the EEG tells us quantitatively and objectively that there are significant processing problems in this person's brain. I hadn't shown you this before. We can then localize this function to the brain structures themselves, and we can map abnormalities within the brain to individual structures using a standardized brain from the Montreal Neurological Institute in this software. And you can see on the right all those red colours, this is at the 10 hertz, which is this abnormality here. This is showing the brain map of the areas in which that abnormal activity is occurring in red. And this is in the 14 to 15 hertz range. That's this big peak up here, which is abnormal. And we can see that's on the right frontal and in the left forceps major. So that's actually the area that was shown from MRI. The same areas came out both with functional abnormality as well as with structural abnormalities. So that's the sort of information we get, as I said before, and that I won't go into detail now, but the task for us then is to look at those abnormalities in the brain and say, do they make sense given the other information we have? And one of the things that's very clear, as I've already pointed out, is there's strong convergence with the MRI analysis, the microangiographic changes in the right frontal and forceps major. Here's another example. This is a 55-year-old patient who suffered an assault to the right parietal region, and the symptoms include spatial neglect and left-sided paresis. MRI showed nothing, which is very common. I'm sure many of you might know that if you're in the clinical field, certainly with traumatic brain injury. Here's the EEG, just a sample of it. This is about 6 or 7 seconds of EEG. There's the frequency map of spectral power, and here's the statistical map. There's the 2 standard deviation line there, and you can see here's significant abnormalities in that range, in the theta range. So as exemplifying it there. Here we're looking at the source maps, and we can see this is the area of maximum abnormality at the top. There's 3 slices in our standardized brain, looking down, looking from the side, and looking from the front. Actually from the back, I beg your pardon. And you can see the area of function abnormality is exactly in the region where he was struck in the accident, that the MRI showed nothing. And here we've done a 3-dimensional mapping of the brain. You can see here's the area of functional abnormality of the right parietal region, the area where he was struck. And what I've shown here, we're just doing an animation of the EEG in that area. As we're taking the EEG, you can see that area and a few others are just lighting up over time. That's the area that the person was struck, which didn't show up on the MRI. So that's a pretty impressive example of a head injury and showing through the EEG where the abnormalities are, and in this case, consistently with the information that we have. Some other clinical data.
For all those people who may have had a traumatic brain injury and they had an MRI that didn't show any structural damage, can it be worth having an EEG done to get clarification and I guess to prove that there was actually a brain injury?
Well, you're asking that question of someone with extreme prejudice. I really seriously believe it is, absolutely. As I think somewhere else I'm talking about later, there are now MRI techniques or magnetic resonance techniques that are better at identifying, in fact I'm going to talk about it now, I can't think of it, identifying structural abnormalities, but they're normally microscopic. So you need a technique such as diffusion tensor imaging or DTI, which is now becoming more known and understood and available, but is still not commonly available. You have to know about it and ask for it to get evidence of that. So just a little section on how does a TBI or traumatic brain injury or CHI, closed head injury, create such impact on brain function. Many of you may know this, but forgive me, and I'll just go through it. It's very simple. You know, if you have an injury of the brain, a physical injury, what happens is you've got the brain inside a solid bony skull, and if it's high impact, that skull will bang inside, rotate and twist and shear inside the skull, because the skull usually doesn't give way, so the brain has to give way alternatively, and you get all these shearing injuries. You get things like contra coup, with the brain bangs backward and forward inside the skull, and of course that's obviously going to impact upon the structure and by implication the functioning of that very tissue, which is very soft. And you get contusions, swelling, you can get blood clots, but what you also get is what's called diffuse axonal injury, and those are micro lesions usually on the axons of a neuron, which is the output end of the neuron, and it's essentially the white matter injury is damage to what's called the myelin sheath, which are glial cells which wrap around the neurons. They're white matter, and when you do that, you have major impact upon the functioning of those neurons, because the purpose of the myelin that wraps around the axon of a neuron, and we've got 10,000 billion neurons in the brain, many of them with myelin wrapped around them. When you damage that myelin, what you actually affect is the timing with which that axon sends on information from one end to the other to impart that information to the next neuron down the trail. And when you change the timing of that information, you are changing the integrity with which the brain can process information. So it's a bit like your car. When the timing is out, it sort of goes, but it shudders along and doesn't work very well. And when you change the timing of the neuronal processing in the brain, you really change the whole ball game of how the brain can process information and hold it all together, and how one area can connect with another. You change the timing, they're not getting the right information at the right time, and so the analyses that are carried out often fail. And so what gets to consciousness is impaired in some way. And what happens to consciousness is essentially listed in these common problems that occur with a TBI, even with a mild one. You can get learning and memory loss, often short-term, sometimes long-term. You can get mental confusion, attentional deregulation, affective dysregulation, and working memory problems. So anyone who knows someone with a TBI often will see that they really have trouble at the highest level of functioning, at a conscious level, holding information online, maintaining, sustaining attention over time, and dealing with stuff in a continuous way. That starts to fail.
Excuse me, could you explain the intent of attentional deregulation?
Well, attentional dysregulation would be me like looking over there while you're talking at me. In other words, I'm not paying attention to what's relevant. So in other words, attentional dysregulation is where you fail to, in the way I discussed earlier, where the emotional system takes the sensory information in and judges what is the most relevant thing to deal with at that moment of time. And it's usually related to satisfaction of need or satisfaction of goals or avoidance of pain or avoidance of injury. If the brain doesn't work that out properly and attends to the wrong thing, you have attentional dysregulation. So ADHD is a well-known example where you have a lot of attentional dysregulation where kids don't attend to what one thinks they ought to. Yeah.
And number 4, please.
Affective dysregulation, that's depression, anxiety, stress, those sorts of things. Affect is the emotional world. Yeah.
If you have somebody who has brain stroke with all those symptoms and you add ECT to that, would that have a positive or a negative effect?
When you say you do what to that, sorry?
If you have someone that has all back injury,
Yeah.
and then because of the depression and the flat effect, etc., they use ECT to try and help. How does that affect?
How would ECT affect it with an injury like this? Well, ECT, for those of you who don't know, is electrical stimulation of the brain, but very, very high level electrical stimulation, so you're looking at quite a significant charge. And as I understand it, the aim of ECT is to try and perturbate the brain and to reset it. Hopefully it'll fall back into a normal state again. And it can work in some cases. There can be side effects sometimes. So that's what ECT is. Usually it's often used, as I understand it, only in cases like where there are severe depression, intractable depression. So does your question go further than that?
My mind's just going a bit everywhere, thinking about all the concerns, all right?
Okay, right. Okay, so what happens with TBI is very similar to what happens in many other major psychological disorders. You have problems with learning, memory, attention, working memory function. That's common too. And here's just an example of the myelin we talked about before. You can see there's the cell body, there's the axon, which sends information electrical signal goes down the bottom, and at the bottom of the neuron, a neurotransmitter is released. If you get diffuse axonal injury, you have problems with the transmission of that information the way I described before. It's not a trivial problem. That is an image of the white matter fibers in the brain. It's a lot. Okay, so you get problems with those, and often with a traumatic brain injury, the injuries occur variously and serendipitously all over the place, and so the impact can be quite variable at a local level. Okay, so just to summarise that, so diffuse axonal injury causes microscopic damage. Yeah? Yes?
Just wanted to ask the difference between the traumatic brain injury and the acquired brain injury. I mean, if the injury is to the same part of the brain, that's still...
Well, acquired is just something that was that happened presumably accidentally. Traumatic brain injury could be an acquired brain injury. Yeah, it would be an acquired brain injury. Yeah, just a different way of talking about it. Sorry? The question was, what's the difference between traumatic brain injury and acquired brain injury? Yeah, there's a large overlap between them, just different terminology. Okay. Look, I might just skip over that because I think we've been through all that. I won't repeat it again. So let's just quickly go through the main forms of neurotherapy. The first one is neurofeedback therapy. So we've assessed the brain, we've identified what systems are wrong. With neurofeedback therapy, once we've identified what systems are wrong, the aim is to try and get those systems working normally. Okay. So what we do is we put electrodes on the scalp, or an electrode cap if we want to cover the whole head, and we pick up activity from those systems that we've seen to be abnormally functioning, and we use the activity from those systems to provide feedback to the person. So in other words, they're actually seeing what their own brain systems are doing on a moment-to-moment basis. But we don't show them the brain activity itself. What we do is we use a proxy. So we would get them to say, watch a movie or play a game on a computer, and then we would use the brain activity we're picking up on the fly while they're watching the movie, say, and when that brain activity is moving away from statistical normal, where we want it to go, we would say darken the screen a bit. And when the activity in that brain on a moment-to-moment basis is moving towards normal, we would brighten the screen. So now, all of a sudden, we have the person who is actually able to become aware of when their brain is moving in the right direction or not, okay, through what's called feedback. So it's a feedback of their own brain activity. They're observing when their brain activity is going well, as opposed to when it's not going well, because it will vary spontaneously over time. And what this is essentially is operant training. So it's standard operant conditioning, operant learning in the brain, because what happens if the person cares about getting their brain to work normally, okay, when they get positive feedback, so like the screen going bright, what will happen in their brain is that will be treated as positive reinforcement. And when you get positive reinforcement, you get a release of neurotransmitter, dopamine and serotonin, which are the neuromodulators, so the gain gets turned up, which then gets sent to those areas which are active when the brain was doing well, and then strengthens those areas. So it's a brain learning technique. So it's pretty sneaky. It's actually using the brain to train itself on the basis of its own activity. And the learning that takes place, what I've just described, the learning process for operant conditioning, the person who, I'll be with you in a second, the person who discovered that was a guy called Eric Kandel. I don't know if you've heard of him. He won the Nobel Prize for discovering how that learning process takes place at the neurotransmitter level. And he showed that both dopamine and noradrenaline, let me show you here, this is it here, dopamine and noradrenaline are involved in changing the structure of the neuron with positive reinforcement, so that the connection between that neuron and the neuron to which it's connected is increased. Okay, so that's in all the medical textbooks. There's nothing new about that. So that's the technique. So we just put a cap on someone, we amplify the signal, we give them feedback on a computer screen, and they get this positive and negative feedback. This is reinforcement. It's just like when you're learning a skill. Like if you're a golfer like me, you can relate to this. You know, if you're trying to learn to hit a golf ball well, you hit it. Your goal is to get the ball in the middle of the fairway. If you succeed, That's good, your goal is satisfied, that gives you positive reinforcement. So what happens? Your brain learns. How does it learn? Well, you're not aware of what it's doing because that's all happening subconsciously, okay? But the brain starts to remember whatever it was that gave you that positive feedback. That's operant learning. That's how we do much of our learning. So it's exactly the same technique. Here's an example of someone, it's not a very good video, but it's showing, it's hard to see here, but here we're seeing the EEG of the person. On this side here we're seeing the degree of feedback, positive, negative feedback from 0, sorry, pressing on the button. Here we go, try again. Try to press the right button this time. So we can see there's the EEG over time that we're picking up from the scalp. Here are the areas that we're training. We're seeing the number of standard deviations the way they are from normal in this slide there. We're then working out the degree of reinforcements provided, so that's the increasing or decreasing the brightness of the screen, and then that's what the subject would see. They'd be seeing just a sample video I made up here, and you can see how it's going brighter and darker as their brain activity is moving away from or towards normal. And then the brain will retrain and relearn, we hope, usually it does, during that process. But it's a process that takes quite a while. Like any learning of any skill, you've got to keep practicing. So it can take 20 to 40 or so sessions, sometimes longer with some people. Yes?
As I understand it, what you're saying is assuming that there is intrinsic motivation.
Correct.
What happens in the case where you've got something that doesn't have intrinsic motivation?
You don't get any learning. Not with this, not with this method. Well, you can't. If someone doesn't care whether they hit the golf ball down the middle of the fairway or not, they're not going to learn how to hit a golf ball. That's just unfortunate. It's just a reality. So if someone doesn't care whether their brain improves or not, and they haven't got any insight or understanding about that, it's going to be very hard to engage them in an operant learning technique where they have no interest in the outcome. It's unfortunate. Interestingly, it doesn't happen too often. Most people end up somehow being motivated. Even, in fact, if you look at the brightness of the screen scenario, there is actually a high face validity to that. If someone's watching a video, you really want the screen to be bright anyway. So that actually is a positive reinforcement in any case. Yeah.
Do you use the same sort of technique for, regardless of what sort of underlying issues were occurring? Is it the same sort of process?
No, you'd vary the technique according to the problem. You'd vary the protocol according to the problem. In other words, what we're training is very much dependent on what we find is abnormal. That's consistent with the clinical and neuropsychological profile.
So in the video game or movie technique, that would be what changes? How would you change the technique?
Well, that's neurofeedback, but we may or may not use neurofeedback. It depends. In the case of this gentleman mentioned, if the person just has got no motivation, it's going to be a waste of time. So we wouldn't even go there. We try, but if it didn't work, we wouldn't bother. We'd use other techniques, like the ones I'm going to show you, maybe. Okay. So another one is so I've got 5 minutes left. So another one is electromagnetic field stimulation. This is a passive technique. So this is one where we place electrodes on the scalp, and we talked about ECT before. This is very, very low level electrical field stimulation, and there is a long literature that shows that very low level electrical stimulation can actually have positive effects on health. And here we're talking about a stimulation that's, I think the number I often quote is 400 times smaller than a mobile phone field. You know, so small, it's not, you wouldn't even regard it as being invasive. It has been shown that can actually have quite, certainly clinically, there's still more evidence to be got, but clinically, over and over and over again, all around the world, people using this technique are finding that this technique can have quite profound impact upon the functioning of the brain. The question is, how does it work? You can see here, for example, even with such a low field, this is an example. This is the brain scanned before a pulse, and the red is the impact of the pulse on the brain. You can see it's actually quite huge, even at such a very, very low level. It's targeted in a particular way at dominant frequencies in the brain, just slightly offset. And how does it work? Well, one argument is it carries out some sort of resetting role, very much similar to the ECT I talked about before. The evidence is still in on that. Another one, and there is some evidence this, it actually can help work in reducing brain inflammation. And many of you may know that traumatic injury, whether it's physical or emotional, can actually have inflammatory effects on the brain. And there is evidence from animal modelling that electromagnetic field stimulation can actually reduce inflammatory function. In an experiment I saw written up, in one trial, they measured the inflammatory cells in the cerebrospinal fluid via lumbar puncture in a monkey that had been stressed, and they found a reduction of over 50%, which is quite impressive. Another technique is transcranial direct current stimulation. That's where we actually put a constant current, again very small, no more than 2 milliamps over about 35 square millimeters, square centimeters, and we impose either a positive or negative current, and the aim of that is to try and encourage or discourage the activity in the brain underlying the area being stimulated. And there's a large amount of evidence showing that's effective. Much of the work came out of Harvard University for that technique, amongst other areas. There's passive infrared hemoencephalography. That's a technique that involves getting infrared light and then using neurofeedback to try and encourage the brain, using that light information, which reflects the temperature of the underlying brain, to try and encourage the person to increase the level of temperature, which means increasing the blood flow. So that's often used over frontal areas where people have depression. And that's been shown to be clinically effective. And lastly, there is low-level light or laser therapy, which is a technique, again, which involves light going in, and the technique there seems to be, well, according to the literature, seems to work by changing the dynamics of the underlying cell activity, making it more active, therefore producing increased activity in the underlying area. And that is being used increasingly in traumatic brain disorders as well. All right, so I've just got 4 or 5 slides. Can I slip those in? Okay. All right, so this is an assessment and treatment case example. It's a female with a history of stroke, closed-head injury, PTSD, and significant problems with emotional affect and cognition. Head pain in the right occipital region. So in this case, we used an intervention consisting of a mix of neurofeedback therapy, electromagnetic field therapy, psychotherapy, counselling, heart rate variability training, which is I haven't talked about that. That's an anxiety reduction technique. We didn't do a post-EEG on these cases. We very rarely do, because it's expensive to do, so we don't do it unless we need to do more treatment and have to reassess the brain. The normal way of assessing outcome is by looking at clinical and neuropsychological change as a result of treatment. So this is the pre-treatment psych assessment. You can see, if you remember before, all that red means we're 2 or more standard deviations from normal in relation to self-regulation, emotions, depression, anxiety and stress, and cognition in the main. I did a PTSD checklist on this. The person got a score of 65, showing symptomatic issues with re-experiencing, avoidance, numbing, arousal, sleep and attention. In addition, there were a number of significant symptoms over and above these: persistent headaches ranging 10 out of 10, memory at 10, a racing brain at 10, traumatic intrusions we've dealt with up there at 8, hypervigilance was a problem, which is quite common with PTSD, anxiety and attention and concentration problems. Here was that person's EEG, and same sort of style as before. You can see significant abnormalities in 3 different areas, 3 different frequency ranges of the brain. There's the brain map showing the areas that are affected in that brain. And here are the assessment results. You can see this, the pre-scores, the mid-scores, and the post-scores. And you can see we've gone, in the case of self-regulation, feeling and thinking or cognition, from basically all red territory, more than 2 standard deviations below normal, to essentially, in the main, apart from 1, to green and grey, which is normal to superior range functioning. So it's quite a dramatic change. PTSD has shifted from 65 to 56 to 31 over the period of treatment. And the symptoms, they started off in the range of 7, 8, 9 and 10, all went down to a level of 2. So in this case, that was a real example of someone that came in, quite significant change. So that's really the talk. So I've tried to talk about neurotherapy as an approach dealing with brain function and trying to change brain function to improve psychological functioning. We're looking at electrical field activity. What it requires is pre-assessment, looking at the brain using quantitative EEG to identify what areas are not working. We're concerned with then marrying that EEG information with clinical and neuropsychological parameters to make sure we've got a clear profile and know where to go in and treat with neurotherapy, and as needed to use it conjunctively with other intervention techniques like psychotherapy and medication, with working with doctors on that, medical doctors. The effects we find are usually long-lasting to permanent. It doesn't work in all cases. I think a ballpark figure we find is we get about maybe 70% success rate. Sometimes it doesn't work and we still don't always know why. It works synergistically, as I said, with other approaches. But can be used on its own. And in cases where the patient doesn't have the insight or the capacity to effect change in neurofeedback or to undertake psychological therapy, some of the more passive forms such as electromagnetic field therapy or transcranial direct current stimulation can be effective. It's a complicated field. It requires people who usually in Australia now, we've got training and certification standards. We expect people to be registered to practice as a clinician, and on top of that there are a whole bunch of other requirements in terms of understanding the brain neuropsychologically and neurophysiologically, as well as extensive training in quantitative EEG. That's it. Thank you very much.